Thank you, Pritika. Hello, everyone. Welcome to the live today. The White Army is very privileged to have Dr. Laxmi ma'am with us today as our teacher and mentor. And welcome to you, ma'am.
Thank you.
Yeah. Also, we have Ms. Akshata and Chinmayee from Global Institute of Medical Sciences who are doing their third year MBBS and they have volunteered to present a clinical case today. Welcome to you guys.
Thank you.
Yeah. Also, welcome all the active members to this session. And with your permission, ma'am, we can begin the presentation.
Yeah, let's start.
Good evening, ma'am. So, me and my friend Chinmayee will be presenting to you a case of short stature that we later were able to diagnose as Stickler Syndrome. And as we move along the slides, we'll come to the diagnosis together based on all the history and examination and investigations that we did.
Okay.
So short stature is any height that is more than 2 standard deviations below the mean for age and in a particular sex and in a population. And short stature could be physiological, which includes familial short stature, and constitutional delay of growth and puberty, which present with a normal growth velocity. And this helps us to differentiate it from cases of pathological short stature, which have a decelerating growth velocity. And the causes for pathological short stature include endocrinal disorders, idiopathic short stature, skeletal dysplasias, systemic illnesses, and various genetic disorders. This case is a case of Stickler syndrome. It is a genetic collagen disorder which is characterized by skeletal deformities, short stature, ocular and auditory abnormalities. It is caused by a heterozygous pathogenic mutation in the gene coding for collagen, and it could be inherited in an autosomal dominant or in a recessive manner. This case has a mutation of in COL9A3, which codes for the alpha 3 chain of type 9 collagen and is the structural component of hyaline cartilage, the vitreous of the eye, and intervertebral discs. So, to the hospital presented a 4-year-old child with complaints of not gaining height and weight, as said by the mother, since 2 years. And she also noticed that he had short and stubby fingers and toes, and he was not outgrowing any of his clothes. On further history taking, we were able to note down a lot of negative history, which includes no history of short stature or delayed puberty in the family, which ruled out familial short stature. No history of any contact with cases of tuberculosis. There was no cold intolerance, constipation, lethargy, or decreased activity, which ruled out hypothyroidism. There was no history of decreased or increased urine output, which ruled out chronic kidney diseases. No history of breathlessness, easy fatigability, bluish discoloration of lips and tongue noted by the mother, which ruled out cardiovascular involvement. And there was no history of recurrent episodes of cough, noisy breathing, or snoring or ear discharge. There was no history of fatty, frothy, or any foul smelling stools or recurring vomiting or pain abdomen, which ruled out GI involvement like malabsorption. There was no history of frequent fractures and falls, which ruled out other any skeletal involvement, for example, osteogenesis imperfecta. And there were also no history of visual disturbances and hearing impairment, which is important in particular to this case. And there was also no history of recurrent fever, joint pain, or any rashes noted, which ruled out inflammatory or chronic diseases. So,
Okay,
past
I'll stop you here. Go back to your chief complaints. Now tell me, if a mother comes to you with this complaint, what are the things that are running in your mind and what are you thinking of?
Primarily, since he's 4-year-old, we can think that he's not eating food well. He could be a picky eater.
Correct. Very good. So see, basically it is a complaint with not gaining height as well as weight. It's not just height. And mother has smartly noticed some short stubby fingers also. Okay, let's keep short stubby fingers aside. With the history that there is no gain of height, you would tell it is probably a short stature. Okay. Then not gaining weight also tells you that both height and weight are affected. So probably it is like you said, it is correct. It looks more like a nutrition related thing. But what is more that is told by this? Both height and weight getting affected. What are your differentials? What all things run on your mind when I say that it is not just height, it is also weight. Weight and height both together.
Malnourishment in the child.
Correct.
Or
So I
any
think that's chronic malnutrition. Correct. Okay.
any
Then anything else?
malabsorptions.
Malabsorption. Okay. Anything?
Hormonal. So it could be growth hormone insufficiency or thyroid reduction, so hypothyroidism. If he was a little older, precocious puberty could be considered.
Precocious puberty, okay. But usually precocious puberty child coming with weight issues?
No,
Less
no,
likely.
height would be majority.
So it will be a predominantly height complaint. Okay. So basically what we are trying to see is both height and weight is affected. That means nutrition is an issue because nutrition affects each and every cell. So all the cells of the body are affected. One is chronic malnutrition. Second thing is chronic systemic diseases. So under a chronic systemic disease, which is the most common disease that is associated with short stature? Most commonly, that disease only comes with a vague complaint of weakness. And then we see it is usually a short stature child. What are all the systems?
CKD.
Very good. So it's all generally a renal problem that comes with a complaint of short stature, may be with non-specific symptoms like weakness. Now this weakness is because of multiple things because of CKD, either electrolyte problem or just an anemia that gives rise to a non-specific complaint like fatigue. Okay. And so first would be renal when it comes to a chronic systemic disease. The second will be
GI malabsorption syndrome.
Correct. Very good. So most commonly missed diagnosis these days with short stature is probably a celiac disease. Correct. Celiac and inflammatory bowel disease. They hardly do have complaints. Only when you dig up more, they say that he's very, allergic to so many things. He doesn't tolerate food, all of that things. Okay. So generally that doesn't come as a first complaint. They come with a complaint of short stature only. Okay. Second is your GI problems. Okay. Then any other systemic disease do you want to tell which can lead to your chronic short stature?
CVS involvement.
Correct. Congenital heart disease. Correct. Because the heart is pumping so much and there are so much AV mismatch that is happening. All the energy is utilized for the cardiac condition only, thereby leading to a growth failure. Correct. So cyanotic congenital heart disease generally can present with your growth failures. Okay. So in the respiratory,
Cystic fibrosis.
Cystic fibrosis, yes, that again goes to a genetic etiology, correct. Not asthma really. Asthma really, the presentation is generally a little late only after 5 years. So mostly it will be your preterm baby with your bronchopulmonary dysplasias or in the new nomenclature it is chronic lung disease. So either it will be a chronic malnutrition or one of the systems chronic disease, either a chronic renal disease, chronic lung disease, chronic liver disease, like your cholestasis and other things, correct? Or it will be a CVS related cyanotic congenital heart disease, which can present to us with failure to thrive or growth failures, correct? Okay. Do you want to touch upon any other cause which affects all the cells of the body?
Malignancies.
Malignancy so early? No. Okay. Anything else? So all the cell of the body, one more thing is your genetic etiology, correct? Some chromosomal problems like Turner syndrome, anything where every cell of the body is getting affected. That kind of a genetic disorder also can come with short stature and failure to thrive. Okay. So here we are dealing with something which affects all the cells of the body. Correct?
Yes.
Generally, endocrine babies will be short and plump. So their weight will be a little on the higher side for that height. Okay. So at this point, I want you to tell you that when you're examining this child in the growth plotting, you should plot weight for height for this child. Okay. So that will kind of rule in or rule out your endocrinal problems. Okay. If weight for height is less than third centile, that means again the same 3 categories that I discussed, either malnutrition, chronic systemic disease, or your some genetic problems, familial issues. Okay. A plump child, weight for height normal or more than required, then maybe endocrinal is one which groups in. Correct. Yes. Okay. Good. So accordingly, you have taken all the negative history, correct? So first thing you ruled out was probably a short stature, by which you meant familial short stature. And then you have ruled out one by one every systemic disease, correct? So you ruled out your tuberculosis, you ruled out your endocrinal issues by constipation, cold intolerance and stuff. And one by one, you went on telling about the systemic problems, correct? Yeah, you can proceed.
So past history, At 4.5 months of age, he was diagnosed with pneumonia and he was admitted for 5 days and it was managed conservatively. And since then, he has not required any admissions and there was no other significant medical history or food allergies. Antenatal history. The mother was booked
Is
and
it
immunized.
significant? Is that episode of pneumonia significant?
If it was a very severe episode of pneumonia which led to lung destruction, then that could lead to short stature, but there would be a generalized effect. He would have
So
fatigue
basically, if
ability.
it was a severe pneumonia, he would have come to us again. Correct?
Yeah.
It wouldn't be 4.5 months and then he's well off for 4 years.
Yeah.
So this is a single episode of pneumonia. We generally don't take single episode of pneumonia as significant. But if the same child gets another recurrent pneumonia, that is one more episode of pneumonia, then yes, he will be taken significant. That means he's getting repeated lung infections and automatically our differentials will change. So one episode of pneumonia, you need not bother. Okay.
Antenatal history. The mother was a booked and immunized case. Her first trimester was uneventful. The pregnancy was conceived spontaneously and it was detected by UPT and confirmed by a dating scan that was done at 6 weeks. All investigations and scans done were normal and folic acid supplementation was taken. She gave no history of fever with rash, bleed PV, drug or any radiation exposure. Second trimester, she felt quickening at 5 months. Iron and calcium supplements were taken, and the anomaly scan that was done and was said to be normal. And she gave no history of diabetes, hypertension, blood transfusion, or any thyroid disorders. Third trimester, she perceived fetal movements well, and iron and calcium supplements were continued, and the growth scan was done and said to be normal. And she gave a history of UTI 3 weeks before delivery, but there was no history of diabetes, hypertension, blood transfusion, thyroid disorders, oligo or polyhydramnios. Natal history. The male neonate was delivered at 35 weeks with a birth weight of 2,200 grams by vaginal delivery with a foot-link presentation with a cord prolapse. Postnatal history. The baby did not cry immediately after birth and required extensive resuscitation with intubation and positive pressure ventilation and had UPGARs of 5 and 7 at 1 and 5 minutes respectively, and he was admitted in the NICU for 2 weeks. He was extubated on day 7 of life to hood box, and it was noted that he had one episode of seizure and was started on phenytoin on day 2 of life. But there were no other episodes that were noted subsequently, and phenytoin was continued for 6 months. Echo was done on day 2 to rule out CHD, and RT feeds were established in first week of life and gradually upgraded to reach full feeds. Pallada feeds were established by 2 weeks of life. Sepsis screen was done during the NICU stay and was negative, and he was discharged on day 18 and was suggested for ROP screening.
So it is pressure, positive pressure ventilation. It is PPV, okay, not
Yes,
PPE. Okay, yeah. And go back in the antenatal history. Do you think if she had any of this positive history, now everything is negative, correct? So basically, she has an uneventful pregnancy. Do you think anything in the antenatal history can contribute to your present complaint? So the present complaint is clear. It's only height and weight problem. Anything in the antenatal history that can contribute to your present complaint?
Fever with
Any
rash
clot
in the
infections?
Scotches
Okay.
infections in the
Correct. So fever with rash. Generally, at which trimester does this come?
first trimester.
First
Correct.
trimester.
First trimester. Do you want to tell any more complaint that can come and is very classic of rubella?
Congenital rubella syndrome.
No, basically you should ask for a post-auricular lymphadenopathy for mother. If she felt any node or some mass kind of a thing just behind her ears, that is nearly a surrogate marker to tell that it is a rubella infection. Okay, that is one thing. Okay, taken. So TORCH group of infection can present with intrauterine growth restriction, which can continue once the child is born, leading to extrauterine growth restriction later on coming to us with short stature or undernourished child. Correct? Okay, taken. Any other history? You said diabetes, hypertension,
Yes,
Thyroid
GDM. GDM
Correct.
of PH.
Okay. GDM generally presents with what? Big baby or small baby?
Big baby.
Big
GDM
baby.
is big baby. Thyroid,
Why?
hypothyroidism in the mother can lead to cretinism in the baby, so that would present with a delayed and retarded growth of the baby. as it
Correct.
goes.
Okay, generally more than the weight, it will be a developmental issue because still the baby is inside. Mother's thyroid takes care. So if mother also has hypothyroid, then the child can be cretin. Correct. Okay. Why is diabetic child, I mean, GDM babies, born more for their weight or large for gestation age? Why is
Overt
it?
diabetes in the mother will lead to hyper insulinemia in the baby. So insulin levels in the baby will stay as is for about 28 to 30 days after delivery. So that will cause more fat deposition in the shoulders. So shoulder dystocia is more common in them.
So this whole process, what you're telling me, it happens in utero only, not once the child is born.
Okay.
So maternal hyperglycemia leads to a fetal hyperglycemia. Fetal hyperglycemia leads to fetal hyperinsulinemia. Now, insulin being an anabolic hormone will start depositing fat in the shoulder pads, making it easy for the shoulder dystocia. Correct. So this whole thing is called as Pedersen's hypothesis. Okay. And the vice versa, like you have a mother with hypertension, chronic hypertensive or chronic diabetic now gets pregnant. Okay. And then she generally delivers a child who is small for gestation age or a IUGR child. Now, this is because diabetes as well as hypertension in the mother can lead to placental insufficiency. The first wave and the second wave of placentation that happens can be impaired in the very beginning, leading to a thin placenta, poor placentation, giving rise to a placental insufficiency. And this child can be a IUGR child. Okay, so intrauterine growth restricted child. And we all know that intrauterine growth restricted child, once they grow up in future, they're all prone for adult onset diseases like diabetes, hypertension, asthma, all of these things. This concept is called as, do you know the hypothesis name?
Baker's hypothesis.
Barker's hypothesis.
Barker's hypothesis.
It is Barker's hypothesis. So both of this should be known. Okay. So if this mother had PIH or diabetes, chronic diabetes before, then there was a good chance that the child was IUGR, and hence thereafter the catch-up growth didn't happen, and so the child has come to us now again with complaints of short stature and undernourished. Correct. Okay. Yes. You can go next. So, but in the natal history, we have a very significant history, correct?
Yes.
So, child has had an episode of birth asphyxia leading to NICU stay, a little prolonged, I can say. Almost 18 days the child stayed. The convulsion was only on day 2. Okay. And after that, it has stayed for almost 18 days. But good thing is, in the first week only, they have tried to establish feeds. So once the child is having feeds that are established within first week, chances of having weight loss and thereby extrauterine growth restrictions will be less. Correct? So the growth would be probably nearly normal. And because sepsis screen is also normal, wouldn't have contributed to the present complaints. This whole postnatal or the natal history wouldn't have contributed anything to the present history. Okay, go ahead.
Family history. He is a third order child born to a third degree consanguineous marriage. There was no complaints of short stature in the family, and the other sibling has a normal height and weight for age. This is the pedigree chart.
Okay. What is first degree consanguineous marriage?
Between parents and child or siblings.
Okay, that is also called as incest. Correct? So mother marrying son or the father marrying daughter. Okay, brothers, sisters marrying each other, which is not followed in India. Correct? So this is first degree consanguineous marriage. How much percentage of genetic material is shared in this?
I think 50%.
Yes, correct. So 50% of the genetic material will be shared in it. Correct. So what is second degree consanguineous marriage?
It's between uncle and niece, nephew and aunt.
Correct. So marrying mother's brother. Okay, the uncle and niece. All of that is second degree consanguineous marriage. And how much percentage of genetic material is shared?
25.
Yeah, so nearly 1/4 of it should be common. Okay, so now tell me, third degree consanguineous marriage is what?
Third degree would be between second cousins.
First degree cousins. Correct. So you can see, it is the cousins there. Okay, so how much percentage of genetic material is shared here?
Less.
It is 1/8.
Yeah, 12.5%.
1/8. Yeah. So 1/8 of the genetic material is shared, thereby increasing the risk of genetic issues. Correct? Yes. Okay. You also mentioned that there is no history of short stature in the family. So what does this rule out?
Familial
Familial short stature.
Very good. So it rules out the familial short stature. Okay. Go ahead.
Diet history. So the total calories that he consumes is about 924 kilocalories, and what is required is about 970 kilocalories. So it's about 4.7% deficit in calories, and proteins are consumed adequately in day.
Correct. So your first diagnosis at the time of history was only malnourished, right?
Malnourished.
So it is kind of ruled out here in your diet history. It is nearly good. Okay. So you have to remember few diet history, like, it should be like on the tip of your tongue. For example, one medium sized chapati, the calorie is around, how much is the calorie in a medium sized chapati?
80 to 90.
80. And what is the protein?
Protein will be 2.5.
Around 2 grams. Okay.
2
So you
grams.
should remember chapati, one thing. What is the calorie and protein in milk? Now, this milk, once you tell, you have to mention whether it is a cow milk or a buffalo milk. Okay. So, how much is the calorie in a cow milk?
Milk is about 72.
72.
So, it is roughly taken as 67 to 70 calories. Okay. What is the protein?
Protein is
3.
3.3.
So, the best way to remember this is, you know what is the calorie and protein of human milk? Every 100 ml of human milk or breast milk contains 67 kilocalories. And a term human milk roughly has 1.1 gram of protein. Okay. Cow milk 100 ml will have same 67 kilocalories, but it will have 2.2 gram of protein. The buffalo will have 77. So they tell, no, buffalo milk khate you gain weight. So it has 10 kilocalories extra, but protein is 3.3 gram. 1.1, 2.2, 3.3. This is the best way to remember the calorie and protein in 100 ml of milk. Now your question is 1 glass of milk. So you should define how much ml of milk it is. Okay. So you should ask mother, try to quantify the ml and then write the calories. Okay. Same way you should be able to tell about the rice and sambar. So one medium sized cooked rice will have around how much kilocalories?
110.
Yes. So around 100, and protein will be 2.
2 cups.
Okay. One normal cup. So one normal cup का कितना measurement होता है? How much is your measurement of cup?
Roughly
So at
250.
this point, I think I'll explain you. So 1 teaspoon is 5 grams. Okay, T small t, TEA, utna hi hai. So 5 grams. 1 tablespoon is 15 grams, 3 times the teaspoon. Okay, so generally you should remember that is the measurement. So if you tell 1 teaspoon of ghee is put, that means around 5 gram of ghee is put. And we know ghee is fat. So 1 gram of fat gives how much kilocalories? Okay. May not be directly related to the case, but I want you guys to know the basics of diet history. Okay. So 1 gram of carbohydrate gives 4 kilocalories. 1 gram of protein gives 4 kilocalories again. 1 gram of fat gives 9 kilocalories. Correct. So that means 5 grams of ghee will give 5 into 9. That is 45 kilocalories. That is why you see in OPDs, what do we tell? Ghee dal ke thoda khilao. Because that will make it energy dense, although there is no protein in it. Correct? That's how your measurements will help you. So 1 teaspoon is 5 gram, 1 tablespoon is 15 grams. 1 normal katori is your idli size, idli donne. Okay, that katori is roughly 150 ml. And 1 cup, when you tell, it is the soup wala cup that we take. It is around 250 ml. Okay. So much basic measurements you should be knowing, so that you can ask leading question to mother. What is the size of the cup she uses? She might be using a very tiny cup. It might be size of the katori. Correct? So that you should be able to ask. Okay. And yeah, 1 apple and banana you have put. Yeah, makes sense. Biscuits also, ideally, you should ask which biscuit also. Okay, whether it is a Parle-G or Good Day, whatever it is, so that you can see on the wrapper the total calorie and the protein requirement. We all should read the labels and then put it. Okay. Yeah. So overall here he looks, by your calculation, the calorie requirement looks okay, and the protein looks almost very good intake. Okay. Yes. I'm surprised how a child with good protein intake has come. Generally, all are protein deficient. What is 2? 2 sweets has 2 grams.
Mom, she said she gives him some kind of a candy or some peda in the evenings.
Okay. I don't think it will have any protein. Okay. Anyways, for the present case discussion, I'll keep this as normal. Yeah. So nutritionally, there doesn't seem to be any deficit. Okay. Yeah. Go ahead.
Developmental history. All domains, he was up to date with all the developments. But gross motor, the mother, these are the milestones she told. So at 4 months, he was able to hold his neck. And 8 months, he was able to sit without support. And at 12 months, he was standing without support. And after a year and a half, he was able to walk on his own without support. And at 2 years, he was walking up and down the stairs. And at 3 years, he was walking up and down the stairs with alternate feet. And 3.5, 3.5 years, he was also going downstairs. And he has not yet had not yet attained hopping when we saw him. And fine motor, the mother didn't remember exactly when the milestones were achieved, but she said that compared to his older sibling, he achieved them at the same pace, and even compared to his other peers. And at present, he is able to copy a circle on a piece of paper, molds clay. He's able to string beads, and he also uses his non-dominant hands to stabilize his objects or any toys he's playing with.
When does handedness come?
Ma'am?
When does handedness come? Hand usage, predominant hand usage come by?
By 1 year.
1 year? No.
So up till 1 year is bidextrous.
Correct. So first you start with bidextrous approach, then the child will start grabbing things with one hand. So that is called unidextrous approach, but that is not handedness. Okay. So I am right-handed, someone is left-handed. This predominant hand usage comes by 3 years. Okay. So any handedness before that, at least by 2 years. So any handedness that occurs before 2 years, we really need to rule out CNS problems. That means one side of the body probably is used less. Okay, so it can be an indirect sign of hemiplegia for us. Okay, so it is roughly 3 years, but 2 years is also accepted. Okay.
Social and adaptive development. At 2 months, he had a social smile, and at 3 months, he recognized his mother. 6 months, he had stranger anxiety, and at 9 months, he was waving bye. And at 2 years, he was able to ask for food on his own. And at 3 years, he shared his toys with others, and he was able to tell his full name. And at 4 years, he plays within a group cooperatively. And language, at 1 month, he's alert to sounds, and at 3 months, he was cooing. At 4 months, he was able to laugh out loud, and at 6 months, he was speaking with monosyllables. At 9 months, bisyllable words, and at 12 months, he knew 1 to 2 words with meaning. By 18 months, he was able to say 8 to 10 words were in his vocabulary, and at 2 years, he was able to speak in 2 to 3 word sentences, mainly asking questions. And at 3 years, he was able to tell short stories. So to calculate his developmental quotient, we use the formula developmental age plus chronologic age divided by 2. So roughly, since his development is up to age, we can say his developmental age is also 4 and chronological age is 4. So developmental quotient will be roughly 4, that is roughly 100%.
Okay. You can also calculate it as last attained milestone, generally attained, and the baby's attained. It is into 100. So everything is achieved appropriately. So it rounds off to 1 into 100, that is 100%. Okay. When do you call it as developmental delay? I mean, by DQ wise, do you want to give any cutoff below which it can be called as delay?
60 to 75.
So that is the reason we calculate DQ, correct? So anything below 70% is taken as delay in any of the milestones. And if we have 2 milestones with the DQ less than 70%, then it is called as global developmental delay. So that is because that is called global because each of these milestones are intricately connected. For example, if the child is not able to hear well, language as well as your social milestones both get affected. Correct? If there is gross CNS problem, not just gross motor, even fine motor also is affected. So when 2 are affected, that means there is a global problem. So that's a global developmental delay when you have 2 milestones, 2 domains less than 70%. Okay.
So immunization history, all his vaccines were given according to the national immunization schedule, and optional vaccines were not taken. So at birth, he received BCG, OPV, and hepatitis B. At 2.5 months, 4 weeks, he was given OPV1, IPV1, and Penta1. And at 3.5 months, he was given OPV2 and second dose of pentavalent. And at 4.5 months, he was given OPV3, IPV2, and Penta 3. And at 9 months, he received first dose of MR and vitamin A. And at 1.5 years, he received MR2 and vitamin A, the second dose.
What is the dose of vitamin A below 1 year?
1 lakh.
1
months, 1 lakh units.
Very good. And say this child came to me at 1.5 years of age with a weight of 6 kgs. That time the mother's complaint was not gaining weight. That time what's your dose?
2 lakh.
2 lakhs.
So that's the catch. So below 6 months, it is always 60,000. 50,000. Below 1 year, it is always 1 lakh. And above 1 year, it is always 2 lakh. This is standard, correct? But if a child comes to you above 1 year with a weight of less than 7 kg, then you have to give 1 lakh. Can you tell me the reason why we are so keen on vitamin A dose here? We generally don't do this with other vitamins, correct? So why am I so keen? What kind of vitamin A is?
Fat soluble.
So chances of? What is the problem with fat soluble
hypervitaminosis?
Very good. So chances of toxicity is there when it is a fat soluble vitamin. That is why we are keen on the dose. So any child below 7 kg, universally it is 1 lakh. Only if it is above 7 kg, you should give. And above 1 year, you should give 2 lakh. Okay? Yeah. Good. These are all just extra questions which will be asked in most of the case presentations. Okay? Not directly related to the diagnosis.
So then now we move on to examination.
Okay.
So on examination,
I'll stop you here. At the level of history, can you tell me the summary? You summarize the history.
So we to the OPD presented a 4-year-old child.
I think you missed the socioeconomic history, right? Yes, socioeconomic history. So socioeconomic history is very important in short stature. I'll tell you why. At the end of the class, I'll tell you. So assume it's a middle class family. Okay, now summarize it.
Okay, so here to the OPD came a 4-year-old boy with short stature, failure to thrive with short and stubby fingers and toes, and his development was appropriate for age, and there was no family history of short stature, and his there was no nutritional deficiency as well, so we ruled out malabsorption or malnutrition, and there were no signs of chronic diseases, no symptoms pointing to any chronic diseases.
So whenever summarizing, no, it is always best to summarize it backward. So you would say a 4-year-old child coming from a middle class family, immunized up to date, developmentally normal with a DQ of 100% in all the milestones, with no significant antenatal history, but a significant natal history of birth asphyxia and NICU admission for 18 days, with significant past history of 1 episode of pneumonia, now has come to me with a complaint of. So the same history what you have done, no, you go reverse. So that you give a summary to the person who is hearing and he hears it like a story. So now that person has a complete picture of what this child is. And then you tell has now come with a complaint of not gaining weight as well as height. With no complaints directing towards a chronic systemic disease. And there is no history, no similar family history. Okay. So at the end of your history, you are dealing with a child of short stature. Okay. And at this point, you should be, when it comes to a short stature, you should be able to answer 3 things. One is whether it is a well child or an unwell child. That means, is it a sick child or a stable child? So what category do you fit this in?
Stable.
Stable child. So that means once you tell it is a stable child, in the sick child, your chronic systemic diseases come. So your CHD, chronic liver disease, chronic kidney disease, these will not come only with stature problem. They'll also come with other symptoms. So probably you are ruled out a major chunk of chronic systemic disease out in this case. Correct? So once you know it is a stable child, next question you should be asking is whether there is a developmental delay or no. Is there a developmental delay?
No.
No. Correct. So if it is a developmental delay plus, that means there was a delay, what do you think the diagnosis will be?
Any syndromic short stages,
Correct.
downwards.
Very good. So one is syndromic problems, that is genetic problems. Correct. In endocrine, do you want to think anything?
Thyroid, hypothyroid.
Correct. So hypothyroid child will always also come with developmental delay.
Mental
So at the
state.
level of history only, you have ruled out your hypothyroid.
Mm.
Correct. So your the endocrinal issues which come with developmental delay like hypothyroidism is ruled out. Okay. And genetic, we still are not completely ruled out. We just know that it is a genetic thing which still affects all the cells, but probably not having special affection towards brain. Correct. So genetic is still in the list. Okay. Now when we know the developmental delay is not there, probably your hypothyroidism is ruled out. Now the third question is always proportion. Now this we will answer in the examination part. Correct. Whether it is a proportionate short stature or a disproportionate short stature. So at the end of the history, we have a short stature. So what do you think the cause of short stature is here? Is it familial?
No, not
No.
familiar.
No.
It's
So at the level
pathological.
of history only, we have ruled out your familial short stature also. Can it be constitutional?
No.
Yeah,
It can still
Yes.
be.
can be.
Correct. It can still be because she says the problem is from 2 years. So even in constitutional and familial, both of them, they will be okay till 1 year. Their birth length will be fine. They will be okay growing till 1 year. After that, they'll start dropping the centimeters. Okay. And here also we have the complaint from 2 years of age. Correct. So it can still be constitutional. Definitely not familial because family history of short stature is not. Correct. So first is probably constitutional because first is always most common things. The always differential goes from most common to least common. Correct. So first differential would be a short stature, secondary to constitutional delay. Okay. The next, what do you want to keep? Do you want to keep endocrinal?
Growth hormone deficiency
Correct. It still can be. Growth hormone or any endocrinal issue, again, which affects every cell, can still be your second differential. Correct. So we'll still keep endocrinal in our second list. Third, can malnutrition be the cause here?
No.
Probably not, because your nutrition looks okay. From your diet history also, it is nearly ruled out. Correct. So less likely it is a chronic malnourished child because mother says the other two kids are growing well with the same food that she is preparing. Correct. So probably not malnutrition related also. So the third one in the list will be what? Chromosomal. Okay, genetic bar chromosomal. So these are your three differential diagnoses at the end of history. So this is exactly how every case has to be presented, not just a short stature case, any fever, cough, cold, or any common complaints that you present. You should be able to come to a differential diagnosis 1, 2, 3 points in favor, points against it. Okay, that's how you scratch your gray matter and make it more interesting for you guys to read. Okay, so at the end of the history, we have short stature. First, probably could be a constitutional delay. Second, could be endocrinal issue. Third, if not anything, ruled out anything, then probably it is a genetic bar chromosome. Correct? Okay. At the this thing socioeconomic history, I told you it is very important because there is a concept called psychosocial dwarfism. That means you keep a child in a depressing environment, like especially in orphanages, those kids who have recently lost or had some major issues at home. They don't grow well. In spite of having good food intake or good nutrition, they don't grow well. The exact reason for this has not been found, but the moment they are relocated to a good area, that means they are relocated to a good place, their height starts improving. So this concept is called as psychosocial dwarfism. So that is why even in a short stature child, your socioeconomic history becomes a significant thing to rule out this thing. Okay. Okay. So now with these three differential diagnoses, you should go ahead with examination. Because now you know your top 1, 2, 3, you will start looking for the signs that will fit into these. Okay, so your eyes will always pick up what the mind knows. Correct. So that's the reason you have to, at the end of the history, you should write this differential diagnosis of 1, 2, 3. And if we are really good with our history taking, our diagnosis will come in 1, 2, 3 only. Okay, that's how it goes. Go ahead.
So on examination, the child was active, alert, and playful. and his vitals were within normal limits. His pulse was 98 beats per minute, measured in the right radial artery in sitting position with regular rhythm, and there was no delay, radial delay. His BP was 98 bar 60 mmHg in the right upper arm in sitting position. Respiratory rate was 25 cycles per minute. The temperature was 98.7 degree Fahrenheit, and he was afebrile. And SpO2 was 98% in room air. And on general physical examination, we noticed no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema.
Your fecal sign, correct?
Yes.
Okay. In the pulse, you have missed one thing. What is it? You told about rate. You told about rate. You told the location. You told rhythm. I assume you are telling normal volume.
Yes, no.
Correct? Volume also you are telling. Then character. Okay, you are telling it as a normal character. Then you mentioned about radial delay. What is one more delay that is missed?
Radiofemoral.
Correct. So that also has to be mentioned in all the pulse examinations. Okay. The moment we tell pulse, all of this should come serially. Okay. And this should be strong part of yours. So that in exams also when they ask you, it is like inviting and saying that I know the answers, let them ask. Okay. So that's how it is. So what is radiofemoral delay? Which pulse comes first?
No.
Which pulse comes first? Radial or femoral?
Femoral.
Radial.
No, physiologically, in me and you, assuming we are normal, which pulse comes first? Radial or femoral? Or do they come at the same time?
No, that radiofemoral delay will be present. Radial delay should be.
So physiologically also there is a delay. That's what you're telling.
No, ma'am.
There will be a slight delay.
Okay. So it is basically, now delay is physiological or no? Okay. So physiologically, femoral comes first. Okay. That is because femoral artery is a direct branch of aorta. It is a major artery. Correct. So the pulse is nothing but the wave from the heart that reaches that area. Correct. So this reaches first to femoral with a very brief delay of around 0.2 seconds, 0.2 milliseconds to radial. So in me and you, if we palpate, we always feel femoral first, then is our radial. Okay. So that is the meaning of no radiofemoral delay. And if I tell there is a radiofemoral delay, that means radial felt first, femoral felt later. Now, can you think what can be the cause of this?
Coaptation of aorta.
Very good. So, coaptation of aorta. So, instead of reaching directly to femoral, there was an obstruction in the road. So, the blood had to travel through bypass road, that is collaterals. So, when the blood has to go through the collaterals and reach the distal part of the aorta, it takes time. And this time is very brief in milliseconds. So, that is how you will be able to appreciate your radiofemoral delay. With practice, this comes in the medicine examination. You should keep doing this. Okay. And at this point, you should also mention all the peripheral pulses are well fed. Okay, in the pulse only. So these are the things that we have missed. That is volume, character, radiofemoral delay, and all peripheral pulses. Now, can you go on naming all the peripheral pulses?
Temporal.
Very good. So how do you palpate it? Correct. How do you palpate it?
With
so all pulses are palpated with your 3 fingers only. Don't forget that. Okay. Yeah. So you put 3 fingers in front of your tragus. So this artery is palpated against zygomatic arch. So you should always have one table, the pulse and the bone against which it is palpated. So this is also most commonly asked and you should know it. And where do you palpate? So this is the place you palpate for your temporal artery.
Superficial.
Correct. Superficial temporal artery. What is the next peripheral pulse?
Brachial. Carotid, brachial.
Correct. Carotid. So how do you palpate for carotid?
With our thumb.
You slide down from your mastoid process till the thyroid cartilage. Okay. And against what do you palpate it? Against which bone do you palpate your carotid artery?
Thyroid.
Thyroid?
It's
okay, I think this was a bouncer question for you. Okay, fine. So maybe in future, if you present some cardiac case, we can do in detail, but you should know this. This can come as a question for any case presentation. So it is the tubercle of C6.
C6.
Tubercle of Chesagnee. Okay, it is a named tubercle. Okay, tubercle of Chesagnee or the C6 vertebrae where you palpate for your carotid artery. Okay, which is the next peripheral pulse?
Brachial.
Brachial artery. Very good. So brachial is palpated against?
It is in the cubital fossa.
Medial to your biceps tendon. Correct. So you palpate for your biceps tendon and then just go medial to it. There you palpate your brachial artery and you palpate it against lower end of humerus. Correct? Yes. Next peripheral pulse?
Radial artery.
Correct. Palpated against?
Styloid process.
So this everybody knows. Correct? Yes. Styloid process. Okay. And then this one? Next peripheral pulse?
Femoral.
Ulnar? Ulnar?
Femur.
Correct. Correct. In the midinguinal point, 4 centimeter below the midinguinal point against the head of the femur. Correct. Very good. Next.
Popliteal pulse.
Correct. So popliteal is the most difficult peripheral pulse to be palpated. Every peripheral pulse by 3-finger method only. Okay. That is the most difficult. It is palpated against?
It's deeper in the popliteal fossa.
So it's every pulse is palpated against one bone. Correct. So you should have that list ready. Okay. So it's against the lower end of the femur. Okay. Then next peripheral pulse?
Posterior tibial.
Posterior tibial. And then is your anterior tibial. Correct. So that also you should know. Posterior tibial again?
Medial malleolus.
Correct. Just below the medial malleolus. Not on the medial malleolus. Just below the medial malleolus. So it's your calcaneum bone. Correct. Okay. Then anterior tibial against?
Lateral.
So it is in the first intertarsal space. Okay. And against the sorry, dorsal ispidis.
Dorsal ispidis.
Sorry. So anterior tibial artery is in the anterior. Okay, just lateral to the great toe tendon. So extensor hallucis. You see the full name. Okay, that tendon. Okay, palpated against which bone also you should find out. Dorsalis pedis. Which bone?
First intertarsal space.
Against which bone? It is navicular bone. Okay, so this list you should be keeping ready for all your case presentations. Okay, yeah, go ahead.
So on next is anthropometry. So on anthropometric measurement, we noted that his weight for age was 9.7 kgs as expected to 16 kgs at his age, which on plotting in the WHO chart put him at -3 standard deviation. And his height for age was 79 centimeters, which expected height for his age is 102 centimeters, which also again put him in -3 standard deviation. His weight for length fell in the 0 to -1 standard deviation part of the chart, and his head circumference was 49 centimeters and expected is 50.5 centimeters for his age, which put him in 0 to -1 standard deviation. And his mid upper arm circumference was 15.5 centimeter. The expected mid upper arm circumference is 16.5 centimeter for his age, which also puts him in 0 to -1 standard deviation.
So at this point, you can see the length is definitely below 2 standard deviation, so it is short stature. Whereas your weight for length is normal. Okay, so weight for length is normal. So weight for length, if it is more likely to be your endocrine issue. Weight for length is less, then more likely to be your chronic systemic disease. That means something which is affecting all the cells again. Okay, more so a failure to thrive picture it will be. Or a severe acute malnutrition kind of a picture it is. So that is also ruled out because our weight for length is normal. So our main concern is your length for age is less and weight for age is less. Okay, weight for length is normal. So probably weight is not our concern anymore. Weight for length is normal. Okay. Now, in this growth chart, see, growth chart gives you a lot of information. So first thing is we know it is short stature. Second thing, you should be able to tell me the height age now. What is the height age in this growth chart?
2 years.
Okay, so what you should do is this height of how much centimeter it is? 79 centimeters is achieved at what age?
Around.
So generally, what is the length at birth? What is the length at birth?
50 centimeters.
50 centimeter. What is the length at 1 year?
75.
Right.
Okay, very
75.
good. So at 1 year, it is 75 centimeters. At 2 years,
87.5.
correct. So it is somewhere between 1 year and 2 years. Correct. So the height age here is somewhere between 1 year and 2 years. This is a way of orally telling it because you know how the height grows. Say you want to tell it more accurately, what you do is you draw a line horizontally from the blue dot that you have plotted. Okay, backwards, and see at which point it cuts the 50th centile. Okay, now if you can draw for me one horizontal line from this length ka blue dot, if you draw towards the draw backwards and see at what age it cuts the 50th centile, and then yes, correct, huh? So that is the 50th centile, correct? So if you put a dot there and go again on the x-axis and see how much months it is, so that will be your height age.
Roughly 15, 16 months.
So 15 to 16 months, correct? So the height age here is 15 to 16 months. Clear? So from your growth chart, you understood that the height age is less than the chronological age. Correct? Okay, now here only we should also be knowing about bone age. Now bone age is calculated using X-rays. Okay, I think we'll go about it next. Okay, and also one more thing you should be knowing here is you should be able to plot the child's individualized growth chart. So for that we have the concept called mid-parental height. Correct? You've calculated, I guess. Yeah.
Yes, ma'am.
Yes, ma'am.
Go ahead. I'll explain it there.
So these are also similar charts. This the first slide was WHO chart. This is WHO and IAP combined chart.
Correct.
Again, this is height or only length and height
So
chart.
for all your theory purpose, use WHO chart till 5 years and after that IAP chart. The left side chart that you're telling, no, combined chart is generally a pediatrician friendly chart. So this is for the busy, actively practicing busy pediatricians because they can't keep two printouts. It's better to keep one printout. So for your theory and learning purpose, I think you stick to 5 years tana, your WHO chart and after that IAP chart. Okay? Okay.
So mid-parental height. For this we measured the mother's height, the father's height. So the mother's height was 148 centimeters, the father's height was 155 centimeter. To calculate mid-parental height, we add the mother's height, the father's height, and we add
Divide by 2.
Divide by 2, and plus or minus 8 for the target height, which we
so
also
plus or minus 6.5 centimeters. For boy baby, it is 6.5 centimeters. For girl baby, it is minus 6.5 centimeters. So this is boy baby. You have added it and you've got a mid-parental height. Now tell me what will you do with this mid-parental height?
So the mid-parental height is the ideal height that the child should achieve. So we plot this on a graph. So we plot it using target height. So for target height, we do plus and minus 8 centimeters. And we plot it at 18 years. So
correct. So
we get a
at
range.
18 years, the last chart, you should go to 164. 164 plus 8, 164 minus 8. So plus 8 becomes the 97th centile for that child.
Yeah.
Minus 8 becomes the third centile for that child. And retrospectively, you start drawing towards the baseline again. So that means what? You have created an individualized growth chart for that child. So the new 97th centile and new third centile are different. Now you will see whether the child is falling within this area now. If it is falling within that area, then it is probably a familial short stature. It is no more pathological. If now the child is still below it, then yes, it becomes a pathological short stature. Okay. So this you have to draw on a growth chart. Okay, go ahead.
And then we moved on to upper segment and lower segment ratio. So the upper segment, lower segment ratio was 1.46:1, which pointed us to disproportionate short stature.
Okay, tell me what is the upper segment? How do you measure upper segment?
Upper segment be from the occiput, the vertex of the head, to the pubic symphysis.
How did you do that? You made this baby stand?
Yes, we made the child stand against the wall, and we marked. We held a flat surface on his head, and we marked it on the wall up till and we also marked the point at the pubic symphysis, and we measured it against the wall.
So that is the catch here. See, every centimeter change can change the ratio, correct? So the best way to do upper segment measurement is you keep a stool. stool against the wooden board of that height measurement and make the child sit on it. And now you know the height at the head, and then you subtract the height of the stool. Okay, you exactly can't localize your pubic symphysis, correct, for your upper segment, because it will go till your coccyx, the upper segment, correct. For your lower segment, you can do this. From the pubic symphysis, just drop the tape down till the foot. So you can measure lower segment in a vertical position, I mean standing position. But for your upper segment, you should take help of a stool, make the child sit on the stool, check the total height minus the stool height gives you the upper segment. Either of the ways you can do, but you don't tell that from head to pubic symphysis you measure for upper segment. Okay, so that's the point. Clear? Okay, you measured upper segment and lower segment, and you told the upper segment and lower segment ratio also. What is the normal upper segment lower segment ratio at birth?
1.7:1.
Okay, how does it
It
change?
keeps on decreasing. It becomes 1.5:1 at the age of 2 years.
Okay.
And then
1.3:1 at 3 years, and at 3 years it becomes 1.1:1, and by
at 7 years, 1.1. It will be equal.
So equal at 7 to 10 years of age. Correct? Between 7 to 10 years of age, it becomes equal 1.3:1 at 3 years of age. Okay. Okay. So yeah. So that means your trunk grows. So that's how your upper segment, lower segment goes on reducing. So at birth, the limbs are shorter and the trunk is a little larger. Okay. So that's why you have upper segment being a little larger. That is 1.7:1. Okay. For this age, what it should be, upper segment, lower segment? Now he is
between 1.3 to 1.2 for his English.
Correct. And he is grossly more. Correct. So it is around 1.5:1. So that means what? Your upper segment or the thoracic, I mean your trunk is probably okay, but your limbs are not growing. Correct. So that's what it tells. Your limbs is the problem. That is what it tells. Okay. Yeah. Good.
Then the arm span is to height ratio was 0.93:1, which is appropriate for his age. Around his age, it should be equal. So this measurement was fine. So then we moved on to segmental measurements. So segmental measurements, his arm measured, upper arm measured 16 centimeters as opposed to the expected of 18 to 20 centimeters for his age.
Where did you get the expected from?
Ma'am, we refer to some orthopedic journals. It was a research.
So it's available only in articles. That's why I asked you. Okay.
Yes,
yeah. So the chart as well as the expected measurements is only in the articles. Yeah. Good.
And it was so his upper arm is rhizomelic, and his forearm measured 13 centimeters as opposed to 15 to 17 centimeters, which is normal, which pointed to mesomelia. And his hand measurement was 9 centimeters as opposed to 10 to 11, which is slightly normal. It is little less, but can be considered as normal.
See, this was some 7 centimeter. What is the term used?
Acromelia.
Very good. So it is rhizomelia, mesomelia, and acromelia. So respectively telling all different kind of diagnosis. Okay, yeah. So we have a child who is rhizomelic as well as mesomelic.
Mesomelic in the upper limb. In his lower limb, his thigh measured about 21 centimeters as expected to 23 to 25 centimeters, which pointed us to rhizomelia again. And his leg was 22 centimeters. The normal is between 20 to 22 centimeters, which is normal, and his foot measured 14 centimeters, and the normal is 14 to 15 centimeters, which is again normal. So his upper limb is rhizomelic and mesomelic, and his lower limbs was only rhizomelic. And we plotted it on graphs again.
Okay, so grossly, yeah.
Okay. And on next was head to toe examination. So on head to toe examination,
here comes your third question. I told you, no, the first question was whether it is a sick child, normal child, developmental delay plus minus. Third was whether it is a proportionate or disproportionate. So now we are dealing with a disproportionate short stature. And the moment you know it is a disproportionate short stature, you should know it is generally your, what is your first differential?
Dysplasia, skeletal dysplasia.
It is skeletal dysplasia. So disproportionate means what? Probably the trunk is paired or trunk is the only one which is affected. Correct. So if the ratios were reversed, that means it was a short trunk, like in your skeletal dysmorphisms of your vertebral columns. Correct. So a broad heading would be a skeletal dysplasia. Call a low set here. How do you tell it is a low set here?
Ma'am, we join the between the line between the eyes and the ears will be placed much below the.
So normally, how is it?
Normally, the tip of the ear crosses the line. It moves above it.
So at least 1/3 of the ear should be above that line. So it's the line joining the outer canthus. Okay. So if that line K, 1/3 of the ear is generally above it. If it's below that, then it becomes a low set teeth. Okay. Yeah.
The other head-to-toe findings were normal. He had slight lumbar lordosis in his spine, which could be physiological at his age. And his limbs were short bilaterally. And in his hands, he had a flattened hypothenar eminence, short stubby fingers or dactylly. And the other head-to-toe
But his
findings.
hand length came normal to us, no?
Yes, ma'am.
So in the picture, he looks a little acromelic.
Yeah,
It looks like an acromelic
yes,
hand. Yeah.
it was little on the graph when we plotted. It was a little below the standard deviation, but 9 centimeters was normal according to the.
Okay. Do you want to tell any significance of the flattened hypothenar eminence? Also, just to go back, your retrognath is also a subjective diagnosis, and usually you see the face from the lateral side. And if you feel the jaw is pushed back, then you call it as retrognath. Okay. Here he doesn't really look like a retrognath. Long philtrum, I still agree. He has a little longer philtrum. Okay. Low set ear, definitely yes. Otherwise, he looks okay. Yeah. Go to the next one. Okay, so basically I was asking you about hypothenar eminence. Any significance of that? Which is the nerve which supplies hypothenar muscles?
Medium.
Median.
Correct. So that means whenever you have a flat hypothenar eminence, you should always cross-check for the reflexes and the movements of those hypothenar muscles to rule out your entrapments. Okay, nerve entrapment can give rise to a muscle atrophy in that area. And because probably his movements are not much affected, it is not a major complaint to them. Okay, so at this point, once you see a flat hypothenar or thenar muscles, you should always rule out the the nerve which supplies it. Okay, yeah. Good.
The other head-to-toe findings were normal. There were no other positive findings. And his systemic examination was also within normal limits. Normal vesicular breath sounds were heard bilaterally on RS examination. And first and second heart sounds were heard, and there were no murmurs. The higher mental functions were normal. There was no focal neurological deficits. And on upper abdomen examination, there was no distension, any signs of organomegaly, no tenderness or palpation, and there were no visible scars and sinuses.
See, it was a proportionate short stature and there is a hepatosplenomegaly. What all do you think of?
Chronic liver disease.
Liver disease.
Hepatosplenomegaly. Liver के problem में spleen क्यों लाया?
Anemia.
Okay, agreed. Anemia can come. Correct. If there is anemia and there is extramedullary what is that? Hematopoiesis, yes, spleen can get enlarged. But why will anemia? Okay, taken. Anemia can present with short stature, but not so severe. Below third standard centile, no. They'll have a little lower growth centiles. Okay, anything more? What is one more cause of short stature that we didn't touch on? Gauchers. Storage disorders. Correct. Storage disorders can come with proportionate short stature because they don't have special affliction for your bone and all. So overall, the proportion of the short stature will be normal, but you will have organomegaly. So short statures with organomegalies can indirectly tell you about a storage disorder also. Even glycogen storage disorders can come with your short stature, but along with that, they'll have other complaints like some hypoglycemia or some anemia, some pancytopenia picture, or they can, if it is a neurologically involved also, they can have CNS complaints also. But there also you can get short stature. Okay. Now, luckily, our systemic examination all is normal, so it's easier for us. Correct? So at the end of the examination, tell me what will be your diagnosis.
So from our the list of 3 things that we had noted, we can rule out endocrinal.
Correct.
But not yet growth hormone, but we can rule out thyroid because there were no signs pointing.
So, but if growth hormone will be there, what will it be?
Proportionate
Short stature.
proportionate short
Ruled out endocrinal. So short stature is a very very interesting topic, because here the investigation is done to confirm the diagnosis and not to diagnose. You should remember. Okay, so whatever investigation you have sent is to confirm. In the last, only in the genetic part, we know it is definitely genetic, so we will send a whole exome. Understood? So in your list of 3, your endocrine is gone. Okay, so what are we remaining with?
Chromosomal, which is now our point of focus. Chromosomal or genetic.
And first one? What was our first list?
Malnutrition. We ruled out.
Malnutrition we have ruled out in history. By your diet history only we ruled it out. What was the first one? Constitutional.
Constitutional.
So your constitutional is still not out. Okay, so constitutional and your genetic bar chromosomal is still in your list. Say this is a girl child. What will you tell now?
Turner's.
It is a girl child. Very good. So the order flips. It becomes genetic first. Because a girl child coming with short stature, unless proved otherwise, you have to rule Turner's. Because not all Turner syndrome come with Turner phenotype. By Turner phenotype, I mean the webbed neck, wide space nipples, your short hands. Not all Turners will come with that. Turner's girls can be a normal looking girl coming to us with either pubertal failure, that is delayed puberty, or they can come to us with short stature. So unlike Down syndrome and all, where you have a proper phenotype, correct? You don't miss that phenotype. Turner can have a normal phenotype and still have problems. Okay. So first would be Turner if it's a girl child. Now because you've told it's a boy child, I'll still keep constitutional delay in the first and then your genetic bar chromosomal. So clear? So at the end of your history and examination only, we have come to our diagnosis. Okay, now we have to now just confirm our diagnosis, either of these two, and tell the parents. Now tell me, how do you find the constitutional delay? How do you diagnose it as a constitutional thing? What is constitutional delay? Or in easy word, if I have to ask you, how do you differentiate the familial and constitutional?
In constitutional, the final height will be within the normal range. Only the growth velocity will be less initially, but it will catch up later on, and the child will attain normal height at the end of his growth period. But in familial, because of his parents' height, the child will be short. There won't be any pathological causes, but the child will slightly be shorter than the normal population.
Is constitutional physiological or pathological?
Physiological.
Correct. Good. So basically, constitutional, the easy way to remember them as late bloomers. That means they are normal. They just bloom a little late. Bloom a little late means what? They attain puberty also a little late. And once the puberty comes, the catch-up growth happens and then they reach the normal height. Okay. But in the first 2 years, they are normal. After that, they'll go below the 3rd centile or cross the centiles. They remain below for a long time till puberty hits and it then reaches the normal height. Now, sadly, I can't tell this physiology to mother, right? She's be like, are you 100% sure this is constitutional? So you should answer her whether it is 100% sure we are constitutional and doesn't need any work. So here in the history level, you should be asking one leading question to parents. If parents are of normal height, as in constitutional delays, you should ask if they had a history of short stature in their childhood, only to reach a normal height suddenly once their puberty came. So most commonly, one of the parents will have this history. They'll tell that, yes, I was very short, and suddenly teachers started telling that I've grown very fast in that 8th, 9th, or 10th classes. So if one of the parent has this history, yes, 90% this child also will go along the same lines as parents, and it can be your constitutional delay. But again, that 90% only, and I can't tell it with 100% accuracy. Correct? So this is one important history to ask in a constitutional delay. Say this parent didn't have it. Okay. So at that time, what I'll do is I will monitor the child for next 6 months and call them back again after 6 months to plot my growth chart. Okay. And if my growth chart shows a good growth velocity. Okay. So at this level, you should also know what is growth velocity. So do you want to attempt what is growth velocity?
It is the rate of increase in height over time, usually
Over
a year.
time. Okay, very good.
And it is reduced in any pathological causes of short stature.
Correct. So that's the catch. So you told me the answer. So what I'll do, I'll call them again after 6 months and plot it again and see if there is a good growth velocity. If there is a good growth velocity, again 99% it is constitutional delay. So from 90% accuracy, my accuracy increased to 99% with your growth chart. And I can reassure parents that let's wait and watch for him to bloom. That is your puberty to hit. Correct? And if this is the growth velocity is low, then probably it is the third category that we are dealing with, that is genetic or chromosomal with 100% accuracy. I'll tell that this is genetic or bar chromosomal, needs a genetic testing only. Either I am sending one karyotyping, specifically more if it is a female baby to rule out Turner, or if it's a male baby, straight away send your whole exome sequencing. Okay. But at this point, there is one more point to add. In the investigation, do you want to do anything?
X-ray.
Now, examination is over. Correct? We are dealing with the short stature, probably constitutional delay or your genetic bar chromosomal. So one is physiological, one is pathological. Correct? So physiological के लिए 6 महीना wait करना है, then बुलाना है, फिर से पूछना है, and at the history level also you have to ask parents how did they grow. Okay, so again lot of good history taking should be there, reliable parent should be there, all of that things. At this point, I'll do few investigations in the child. What is it?
X-ray.
Bone age.
Very good. So basically, I want to see the bone age of the child. So we have a chronological age that is 4 years. We have a height age that is around 15 to 16 months. That is 1.5 year. So 1.5 year wala bachche ka height the child has. So that is your height age. Next, I want to see the bone age. Okay. So bone age best seen by carpal bones. Okay. But there are more sophisticated methods like PILE-ILS method, some radiographic software methods are there, which is for a higher reading if you want. You can see that also. But in a bedside examination, for all kids between 2 years to 12 years, you can take your left hand
non-dominant.
Non-dominant hand. Why so?
Ma'am, X-ray, it might damage the race, it might damage the dominant hand.
More specifically, damage or something else? So dominant hand is more prone for injuries, right? So you can have some minor fractures, many unhealed things, and also it is just a convention to use a non-dominant hand, nothing specific. Okay. Okay, go ahead. Go to the next.
So from summary, Chinmayee will take over.
I'll be continuing from summary. So after all the examination, we have a 4-year-old boy with disproportional short stature, rhizomelic and mesomelic in the upper limb, and only mesomelic in the lower limb. Both his height and weight on the WHO growth charts were below -3 standard deviation. And on head-to-toe examinations, the following features
weight for height was normal. That you have to
weight for height. Yes, ma'am. Weight for height was
purely dealing with the short stature. It's not no more a failure to thrive or a SAM child now. Okay. So weight is normal for that height. So weight is not a concern for us now.
Yes. So short stature clinically can be differentiated as short stature with no dysmorphic features and short stature with some dysmorphic features. As we saw in our head-to-toe examination, there was slight retinognathia, long philtrum, low set ears, which will directly rule out the no dysmorphism differentials. These differentials were further ruled out by our negative histories and general physical examination. Now, coming to the short stature with dysmorphic features, it's again divided into disproportionate and specific syndromic signs. Disproportionate short stature, again, by seeing the upper segment, lower segment ratio, we found out that the child had disproportionate short stature, and more so in the limbs. The limbs were shorter So this will rule out again the short trunk differentials, that is the spondyloepiphyseal dysplasias, multiple epiphyseal dysplasias. So now with the remaining two, short-limbed disproportionate short stature and specific syndromic signs, we did further investigations to come to our final diagnosis. So first, the routine investigations of CBC was done to rule out anemia or any chronic systemic illnesses. TSH was done to rule out hypothyroidism.
Although we
ABG,
ruled it out at the level of history and examination just for a
this
confirmation
was
purpose. And these days, lot of medical legal things, right? So for that purpose, we'll document all of this.
LFT, RFT was also done to rule out any systemic illnesses. Then GH stimulation test was done, which was found to be normal. The main finding here was that of the X-ray. The X-ray of left hand showed absent carpal bones, and there was short, middle, and distal phalanx indicating delayed bone age. The X-ray of left lower limb also showed diaphyseal irregularity at the tibia, and the X-ray of spine showed a slight lumbar lordosis, which might be physiological at this age. Then fundus examination was conducted, which was normal. Then after all this, the whole exome sequencing was done, which finally led to our diagnosis. COL9A3 mutation was seen, which is strongly suggestive of Stickler syndrome type 6.
So without any investigations only, we had come to this diagnosis, correct? So that's how short stature is. Without any investigations, you should come to a diagnosis, and investigations that we do is only for the confirmation purpose. We can avoid GH stimulation, everything also for this child because it doesn't look like endocrine. Correct? Yeah, good. So we have one fancy name, that is a nice syndrome. Okay, Stickler syndrome.
Type 6.
As a diagnosis. Okay. Yeah.
So the treatment part, coming to the treatment part, since this is a genetic condition, there is no specific treatment, but gene therapy has shown promising results in other alleles of this condition. Uh, Conservative management is the only treatment option as of now. Routine ear and eye examination is advised regularly because there may be eye and ear complications associated with Stickler syndrome.
What eye and ear complications?
Myopia, retinal detachment, sensory neural hearing loss.
No, because it's a collagen problem. Correct? Collagen junk may be here, it will affect all the areas. So all places where that collagen is there, specifically more your eyes. Why do you think ear is also involved?
Cochlea.
Okay. Cochlear membrane is one explanation. Second explanation probably is again nerve entrapments. Okay, that can happen. If the head size is growing properly and your foramens are not appropriately sized, you can have nerve issues also, compression issues. Okay, if you're especially your axial skeleton is involved. Okay, yeah. Fine.
Yeah. In case of malocclusion due to micrognathia, mandibular advancement procedure can be done. To prevent retinal detachment, laser therapy can be done, and myopia can be corrected with spectacles. And in case of recurrent ear infections, myringotomy tubes can be used to clean out the infections, drain out the infections.
Again, because of the shape of the ear here, the middle ear and your external ear, the S-shaped ear canal, everything can get disturbed because the head size probably is growing normally and rest of the body is growing smaller. You can have difference in the size of the middle ear, external ear, leading to a repeated risk of otitis media.
So finally, coming to the summary, there are 6 types of Stickler syndromes, and this is just a comparative table of all the 6 types and what complaints they mainly come with. R type, that is the Stickler syndrome type 6, usually come with myopia and hearing impairment. But since our patient doesn't have any eye or ear complaints yet, we can call this an atypical type of Stickler syndrome type 6 because it was proven genetically, but the child doesn't have any complaints as of now. Other complaints can be retinal detachment and skeletal manifestations. In type 6 specifically, cleft palate hasn't been seen, but in other types, cleft palate is a major complaint. So in these type of syndromes, genetic testing becomes important because it will help us guide the treatment plan and screen for other high risk individuals and for subsequent pregnancies.
Pregnancy. Exactly. Maybe not in this child because it is already a third child.
Third
But
child.
if this was the first child, then maybe we had to go for your genetic analysis and genetic counseling for the parents. Specifically with the risk factor of third degree consanguinity also.
Yes, ma'am.
Okay. So if you have parents who are just distally related, not fitting into any of these consanguineous marriage, how will you show it in your pedigree charts? So specifically more common in your northeastern states, where there will be so many relations. There will be weddings happening within similar families.
Yes, ma'am.
Okay, same family, distal relatives, third degree, fourth degree relatives, they'll be getting married. So getting married in the same family is also not a good thing, correct? You still have some common genetic material that is getting shared. Maybe 1/33rd component, 1/32 or 1/64. Okay, but you still have some common sharing. So if you want to tell this, which is not fitting into first degree, second degree, and third degree consanguinity, you can label it as inbreeding. It is labeled as inbreeding and specifically more common in your northeastern states. Okay. Okay, good. So the carry home message from this discussion is you should know to tell your differential diagnosis at the level of history. Dig up your history well. So whenever you tell the history, you should always have a anatomical diagnosis, pathological diagnosis, and then your etiological diagnosis. So because this was a straightforward case, we knew it was a short stature. Okay, but if any other case comes, you should always try to localize the anatomy. For example, a respiratory case comes, you should be able to tell whether it is airway or interstitium or pleura. Okay, so your diagnosis should always have that anatomical, pathological, and etiological. For this child, the diagnosis is short stature, which is again your anatomical diagnosis is globally affected. All the organs are affected. Okay, and pathological probably is your some genetic problem.
Genetic.
It's not inflammation, it's not infiltration, it's not storage disorder. So it is a genetic issue. So genetic problem is your pathological diagnosis. Etiological diagnosis is your pole 9 mutation. So it is your etiology that has caused this. Okay. So same thing if you have any other child, then the etiology becomes either a growth hormone deficiency or a hypothyroid or anything else, whatever diagnosis we get. So you should try to come to this diagnosis at the end of history only. So like we did at the end of history, you should be able to point out 1, 2, 3 diagnosis. At the end of examination, you can add more diagnosis to it. Because if you have found new findings, yes, plus 4, 5, you can keep a list of your differential. But your eyes will always pick up what the mind knows. So at the end of the history, having 1, 2, 3 diagnosis points in favor, points against it. Okay, for each one of them is very important. So that will give you a wide horizon of analysis. I think we are done, correct? Very nice presentation, guys. Chinmayee and Akshata. Good job.
Thank you.
You can case. You can make this case report and publish it with permission from your mentors. Okay. All the best. Okay.
Thank you, ma'am.
Bye. Yes.
Bye.
Done, ma'am?
Yes. Thank you.
Yes. Thank you, ma'am. Thank you so much for a wonderful session. It was really, really informative to all our audiences and all our members. And thank you, Laxmi ma'am, for being a great support throughout. And this is a very special live to us because we have just hit 3 lakh subscribers, and your live is the first live after the milestone. So it's very special to us, ma'am. And thank you so much for your support throughout, ma'am. And we would really have request your support in the future as well. Yes,
Sure.
ma'am. And also, Akshata and Chinmayee, thank you so much for today. And thank you so much from the White Army team.
Thank you.